The next presentation will be about SMA, the introduction of therapies for spinal muscular atrophy has changed the clinical landscape, transforming SMA from a lethal to a treatable disease. Our next speaker, Milos Brkusanin, sorry if I am spelling your name wrong, is working at the Center for Human Molecular Genetics, Faculty of Biology, University of Belgrade. He is the chair of biochemistry and molecular biology. He will speak about SMA from a fatal to a treatable disease. Milos, the floor is yours, and thank you very much for being today with us.
Good afternoon to everybody, and thank you very much for the invitation. First of all, I must say that my connection right now is not very stable. So if there are any problems during the presentation, please give me a signal so that I can at least turn my camera off. Thank you for this introduction. I work at the Center for Human Molecular Genetics, which belongs to the Faculty of Biology in Belgrade. For the past 25 years, the center has been focused on diagnostics and research of rare neuromuscular diseases. And I myself have been involved in research on spinal muscular atrophy for more than a decade now. And currently, I am the project leader of the newborn screening pilot project in Serbia, and I also work on the identification of biomarkers for treatment response to genetic therapies in SMA. We usually start every lecture on SMA with this horrifying sentence that the SMA is the most common genetic cause of death in children, with the average incidence of 1 in 6,000 to 1 in 8,000 children. But the question that I will ask and try to answer is, can we make this phrase a thing of the past? So I will briefly discuss how things used to be in the past. So unfortunately, for decades, individuals living with SMA and their families did not have any hope. What does this mean? We would perform genetic testing for a child, confirm the diagnosis, and then the doctor would usually tell the parents to bring the child back home, to love them, take a good care of them, but also to witness the inevitably progressive natural course of the disease. Of course, some standards of care and support were available to these individuals, such as nutritional care, pulmonary care, physical therapy, or palliative care. And indeed, these standards of care were affecting positively the overall quality of SMA individuals. But however, they were not able to remove the initial cause of the disease. The only prevention that we were able to offer to the affected families were carrier testing, first of all, to see whether other family members are carriers of the disease-causing mutation. And if they were found to be carriers, then prenatal testing was available and offered in each future pregnancy. So genetic testing in the affected families definitely brought immediate benefit for affected families. And in many disease-affected families, this was the only opportunity and way for having healthy offspring. However, in the past several years, we have witnessed the approval of several therapies for SMA, these therapies showed great potential in both preclinical and clinical studies. One of the advantages of these therapies is that they are genetically designed, which means that they directly target the disease cause. All approved therapies for SMA showed a very high therapeutic potential, but only if they are applied before the onset of symptoms, which means early after birth in the so-called pre-symptomatic stage. And this is precisely the reason why we today talk so much about newborn screening as a way of disease prevention. And compared to carrier screening and prenatal testing, which used to be offered only to disease-affected families, newborn screening is offered to every family and should be available for each newborn, bringing equal chance for every baby to be diagnosed and effectively treated on time. SMA is marked by premature and irreversible death of motor neurons in the anterior horns of the spinal cord. So in this photo, you may see that the arrow tips show very thin anterior horns and that the entire arrows point towards normal posterior horns. So these anterior horns are very thin because of the death of motor neurons. What is very important to understand is that in SMA individuals, almost 95% of all motor neurons are completely lost within first several months of life, which as a consequence leads to the muscle weakness and atrophy. And unfortunately, if no treatment is applied, then the disease most frequently has the fatal outcome. Approximately 60% of all SMA individuals develop the most severe type of the disease, which means that they present symptoms very early after birth. They never have the ability to sit alone, and very rapidly after birth, they lose the ability to eat and breathe without any support. Other forms of the disease are less severe, we say milder, but they also carry permanent disability and invalidity. So why do motor neurons die prematurely? The answer is simple, because there is a lack of a protein which is vital for their survival and normal function, and this protein is called the SMN protein. In the DNA molecule of a healthy individual, the information for the production of the SMN protein is contained within a gene which is called the SMN1 gene. The SMN1 gene is the main source of production of the SMN protein, because the SMN1 gene always produces normal functional SMN protein. But however, in a healthy individual, there is also the SMN2 gene, which is called the backup gene. It is only partially functional, and it produces only about 10% of the normal SMN protein. The situation is different in an SMA individual, where there is no functional SMN1 gene, and unfortunately, the only source of the normal SMN protein is the SMN2 or the backup gene. And these 10% of the protein that is produced from this backup gene is not sufficient to prevent the onset of the symptoms. So if we know that in an SMA individual, there is no functional SMN1 gene, but there is the backup SMN2 gene, which produces low and insufficient amounts of the normal SMN protein, we may review the available therapeutic options for SMA. One of the therapies that has been approved is gene therapy, or Zolgensma, which actually represents the introduction of the functional SMN1 gene into the body through one-time intravenous infusion. And this is also one of the most expensive therapies in the world. Another approach to use is to target the SMN2 gene in such a way to make it produce more functional SMN protein and not only 10%. One such therapeutic is nusinersen, which is an antisense oligonucleotide. In other words, it is a molecule which cannot cross the blood-brain barrier. It cannot enter the central nervous system where its action is needed. And for this reason, this therapeutic has to be injected directly into the spine, or as we say, via intrathecal injection. Another way to achieve the same is to use a small molecule, risdiplam, which is taken orally. And it is important to understand that both nusinersen and risdiplam are lifelong treatments. So the situation seems quite simple. We have the disease, we have 3 available therapeutic options, we use the therapies, and we cure the disease. But unfortunately, this is not the case in spinal muscular atrophy. So unfortunately, individuals with SMA are diagnosed with a significant time delay after the onset of their symptoms. The patients with the most severe type of the disease are diagnosed with a delay of 7 or more weeks, while individuals with milder forms of the disease are diagnosed with even longer delay, sometimes up to 1 or 2 years. This diagnostic delay reduces therapeutic efficacy, but it is also fatal in the most severe type of the disease. Why? It seems that these 7 or more weeks is not a long period, but however, I must remind you that in these 7 weeks, almost 95% of all motor neurons are completely lost. And for this reason, such child has completely and irreversibly lost any possibility to sit unsupported, to eat or breathe without support, and even with the therapy comes too late, and the disease unfortunately has the most tragic outcome. So what I would like to highlight here is that in the era of innovative genetic therapies, when extremely high financial funds are spent for treatment of SMA individuals, diagnostic delay represents the major obstacle in achieving the maximum therapeutic benefit. And once again, I would like to highlight the importance of early diagnosis and early treatment. So the reply to my question from the beginning, can we make SMA a treatable disease? Yes, we can, but through the newborn screening. So This is a map from last year presenting different countries of the world and the availability of the treatments for SMA and the availability of the newborn screening. In this map from last year, Serbia has been recognized as a country where treatment options are available, but with no screening implemented. So now I will briefly share our experience to show you how we managed to make SMA a treatable disease in our country. So first of all, what treatments are available in Serbia? The first therapy for SMA came into our country in July 2018 when nusinersen applications started. Up to the present moment, if I'm well informed, we have a total of 35 persons with SMA treated with nusinersen, including 4 adult type 3 patients. Almost at the same time, 8 SMA persons received risdiplam as a part of the clinical study, and up to the present moment, totally 30 of them have received this treatment. Both nusinersen and risdiplam are financially covered by our health insurance fund. Regarding gene therapy, we have 9 SMA patients who received this treatment up to the present moment, and they had all previously been treated with nusinersen. However, until recently, gene therapy was not registered and approved for use in Serbia. And still, it is not financially covered by our health insurance fund. So how did these patients receive this expensive treatment? Through numerous fundraising campaigns. But one of the advantages of these fundraising campaigns is that they enabled raising of the awareness of SMA in our country and the awareness of early intervention. So, bearing in mind that therapies are available in Serbia, and with the emphasis in SMA being placed on early intervention and early diagnosis, we knew even then in 2018 that the newborn screening was the next logical step we had to work on. So for this purpose, in 2018, in the Center for Human Molecular Genetics, we optimized and validated a commercial test for the newborn screening, which used dry blood spots as the initial sample. This technique was shown to be 100% specific and sensitive in detecting SMA individuals with no SMN1 gene. The entire laboratory workflow takes about 4 hours for the analysis of 91 samples. And according to the Statistical Office of the Republic of Serbia, there are on average 180 babies born daily in Serbia, which in other words means that for all the babies born on the same day, the screening can be performed within a single day. So what was our path towards the newborn screening as a way of disease prevention? First of all, in close collaboration with the association SMA Serbia and our clinicians at the University Children's Hospital, we prepared a project proposal which we sent to the Ministry of Health. Unfortunately, our project proposal was rejected without any explanation, which was very disappointing for us at this moment because it made us realize that a huge experience that we had, that the close collaboration, a good idea, that actually this was not a guarantee of success. But nevertheless, we didn't lose hope. And in September last year, the association SMA Serbia organized a roundtable on SMA, where we tried once again to convince the government that the early diagnosis was extremely important. However, they did not understand this, or at least they didn't want to understand it. Luckily, there were representatives of the pharmaceutical companies present in the audience, and they recognized this urgent need to screen for SMA early after birth, and they agreed to provide complete financial support for a one-year pilot project. So in order to establish the newborn screening in Serbia, we decided to start from one maternity hospital, which is one of the biggest maternity hospitals in the entire country, and it is located in Belgrade. And in this hospital, around 8,500 newborns are born annually. So we obtained the ethical approval from the hospital's ethical boards, and upon giving birth, every mom is asked to sign an informed consent if she wants her newborn to be included in the SMA screening. If she agrees, then 2 drops of blood are collected from the heel of the newborn and saved on a specific card, which is adapted for genetic analysis. Then the following day, the samples are transported to the Faculty of Biology, where they are specifically tested for SMA. So, as I have already said, the awareness of SMA and of the importance of early diagnosis was already present in the general public in Serbia due to numerous fundraising campaigns for collecting the funds for gene therapy. However, when this project started, we as project participants tried to spread the main message and the impact of the project to the general public through numerous media appearances. We set some objectives that we wanted to achieve. First of all, we wanted to create organized and coordinated work at different levels of healthcare, which means that we wanted to establish the entire process to work successfully from the sample taking until the approval of therapy and patient follow-up. Of course, the ultimate goal was to prepare the ground for the establishment of the newborn screening at the entire territory of Serbia. And these steps were in accordance with the National Rare Disease Program, which discusses improvement of the availability of the newborn screening and therapies for rare diseases. However, on the right side, you may see some of the challenges that we faced. First of all, in the beginning of the project, many parents refused to participate. They didn't want their newborn to be tested for SMA at birth, usually due to the fear of the unknown or due to the parental anxiety immediately after childbirth. Another thing, we were not able to foresee whether the country would have enough funds for possible positive cases that we may identify in this project. And the main obstacle was, of course, obtaining the government support for the spreading of the screening at the national level. Our pilot project started in April this year, and until today, we have tested approximately 5,000 newborns. Since we included only one maternity hospital, we expected to detect maybe one or maybe none newborns with SMA, but actually very quickly we identified 2 positive cases in our pilot projects. And we identified them very quickly because we confirmed their diagnosis when they were approximately 6 days old. So then the therapeutic options were discussed with the family, and the therapies were approved within 10 days. And for both newborns, the therapies were given when they were less than 1 month old. So the total number of therapies that we approved based on the results of our newborn screening pilot project is totally 3. Why do I say 3? Because we identified 2 newborns, and the first newborn has an older brother who was also confirmed to have SMA, even though he was completely asymptomatic at the age of 16 months. So now all 3 children are given the therapy. During this 8-month period, we established a complete screening and diagnostic algorithm, which means that we now have the way to confirm each positive newborn screening result, to we establish the pathway to determine the SMN2 copy number, to discuss the treatment. But what is interesting, we insisted on pre-symptomatic initiation of treatment in all individuals, including those with 4 SMN2 copies, which are predicted to develop milder forms of the disease. Why did we insist and demand immediate treatment for all of them? Because this way we can reduce or completely prevent the irreversible motor neuron damage, and thus provide completely normal or almost completely normal life for these babies. So what are our achievements? We created the organized and coordinated work at different levels of healthcare. We prepared the ground for spreading of the newborn screening, but still we are not ready for its implementation at the entire country level. Also, we achieved higher rates of participation in the project, because now almost every family accepts to test their newborn for SMA. And we also realized that parents are able to rationally cope with the unexpected SMA diagnosis in their newborn. And we are just about to start a new round of conversations with the government, with the Ministry of Health and the Health Insurance Fund, where we will try to present the challenges and the strategy to implement the screening at the entire country level. And we hope we will be able to do so from the beginning of 2024. So these are some very important take-home messages. First of all, SMA is a rapidly progressing, devastating disease, which, as I said, is caused by the premature and irreversible loss of motor neurons. This is the reason why early diagnosis and early therapy application is essential in SMA, because only this way we can achieve the maximum therapeutic benefit. So regarding my question from the beginning, can we make SMA a treatable disease? I will say once again, yes, we can, through newborn screening, because newborn screening accurately identifies babies with SMA at an early stage before the onset of symptoms, thus giving us the chance to treat the baby in the perfect moment, and to make this baby live a completely normal or almost completely normal life. Of course, the SMA community strongly supports and advocates widespread implementation of newborn screening, and only by our joint efforts we can make this most common genetic cause of death in children a thing of the past. So in the end, I would like to thank you for the invitation once again and for your attention. This is a photo of me carrying a baby, the first newborn that was diagnosed with SMA in our pilot project, when she was only 5 days old, and she received the therapy when she was 17 days old. I really believe that we saved one life, and I'm absolutely sure that this baby will never develop any symptoms of SMA. Thank you very much once again.
Thank you very much for this presentation. It was a great overview of the disease, but also of your stepwise approach in Serbia in getting to a newborn screening for SMA. That's wonderful how you approach this, and this is a great example for all of us. And now I'd like to open the floor for questions. I'm sure you have many questions.
There are some raised hands, so maybe they can just open the microphone or I don't know, Dorica, you name them. I see Ipeg and Liv, you have some questions.
So, I start. Okay. Thank you, Milos. It was a great presentation. Thanks a lot. I have two questions. In Turkey, we have only nusinersen treatment for the time being. And also we have some criteria to keep the treatment because you need to give the treatment in each 4 months. But our government looks to some criteria, for example, increasing the Hammersmith scale and other ones. My first question is, do you have any criteria to continue nusinersen treatment? And the other question, since it is a continuous treatment, how do you manage this timely application of each doses? Because in Turkey, we have to track the process by families. They have to go to the doctor and track the right timing. So we lose time.
Okay, so the first question was, of course, the situation is the same in Serbia. Since our health insurance fund provides financial support for the therapies, they need to see that the patient shows an improvement, which is very difficult because they want to see that a patient is a responder. So what is a responder? It is very an unusual question. Is it something that we can measure on a scale? Maybe a clinician would say, yes, the patient improved for 1 point, but is it significant or not? Another thing is maybe the patient, if the patient is old enough, can say, I have more strength, I have a better quality of life, then it means that he responds to therapy. Maybe it's the molecular biologist who should say, yes, we can see that the neurofilament levels decreased. So this patient is obviously a responder. So we have the same problem, how to prove that the patient responds to therapy. I think that our clinicians have to write a report every year for the National Fund, and that they follow the motor scales. But I am not sure that our fund is so strict. So if you describe any kind of improvement in a patient, they just keep on providing the funds for the therapy. So once that you get into this system of getting the funds for the therapy, if I'm well informed, in order to receive the funds each year, our fund is not so strict. So you just have to show them that there is any kind of an improvement. So your second question was, how do we manage to keep parents coming, if I understood well, at the exact time when they are supposed to come to receive the treatment?
Yes, timely management of the ongoing treatment, I am asking, because normally in Turkey, we have to track these timings and go to the several doctors before each dose of nusinersen. But maybe in your country, the doctors or the health system manage this timely application of the new doses.
We do not have any very effective system. The thing is that Serbia is a very small country, and that patients are treated in Belgrade. So it is centralized, and there are not many patients. Each of them have their own schedule. Each of them has their own clinician at a different institution. So I think that in Belgrade we have 4 institutions where these individuals are treated. So it's not very difficult to organize a visit at the exact date when they are supposed to be treated. Sometimes it happens that due to some other health complications, the dosing has to be postponed for a few days. But I think it's something like to be expected. So we do not have any very effective system. The thing is that the country is small, that all patients come to only several institutions. And I'm saying this because in Serbia, we have around 65 babies born per year. And I know that there is 1 million babies born in Turkey. So I'm making this comparison just to let you know why things are maybe easier in our country than in Turkey.
Yes, yes. Thank you so much. It's great, and congratulations for the newborn screening. All you
Thank
made
you very
was
much.
great. Thank you very much.
Thank you.
Are there any other questions, comments?
Yes, can I make a comment? I am the second one from Turkey. Also, we have started dominating after Epicana. My name is Onur Çakır. I am from Turkey as well. I am a patient advocate. My daughter has a genetic disorder. It's not an SMA, another one under congenital muscular dystrophies. But of course, even though I am an engineer, as you can imagine, we have happened to be kind of a gene engineer actually. Anyway, so thank you very much, Milos, for this presentation. Over the past 5-6 years, this is my understanding. Please correct me if I'm mistaken. But over the past 5-6 years, I have been seeing that there is kind of sort of an era opening actually in technology in terms of these gene therapies, etc. And SMA is one of the leading ones, of course. So I have been trying to understand. We have been in touch with a great team from NIH in the US, not only for my daughter, of course, for the other kids having these serious diseases. So I would appreciate from you and from all other scientists and MDs getting involved in these diseases to show the progresses on on the kids who have been receiving these gene therapies and disease, because it's not easy to convince people, especially who are getting involved in fundraising things, because they don't believe that they still, even some MDs still think that they are under clinical trials. They don't know that they have been approved. So people should understand and see and be convinced that these diseases, these drugs have been helping these kids a lot. So I would appreciate to share more videos or other pictures showing that these drugs are working pretty well, because I personally know, but of course it's not easy. So that's going to be, that would have been my comment. Thank you very much again. By the way, thank you very much for this conference. I just chatted with Arabella in between. So thank you very much who has contributed to this event. Thanks a lot again.
Thank you for the comment. I think it's very important to keep talking about these things, because I really believe that people are very afraid of these new things. Like when people in Serbia hear that we are going to perform the genetic newborn screening for SMA, that we are going to extract DNA from a dried blood spot, that's the moment when they try to refuse the screening, because they think that they will that we will do I don't know what, like clone their child or do some experiments on their DNA. So whenever people hear something regarding DNA or RNA, they have this like inborn fear that something wrong is going to happen. Maybe the reason is the COVID-19. At least in Serbia, we had a very bad campaign regarding vaccines. So I think that people completely lost their faith in science and medicine. And maybe this is just like the time that we are living in, like the conspiration theories, or, you know, so I'm very thankful for the comment that you made, because it's extremely important to keep talking about these things, to show their efficacy, but also to keep talking in a very simple way, so that somebody who is not from the field can easily understand the benefits. Because what I'm trying to at least highlight here when I'm talking with people is that everything that we are doing in the newborn screening for SMA is in the best interest of the child.